So I'm very grateful to the team for inviting me, and very much thank you to Ida and Cassandra for their talk. I will first of all highlight that actually most of pregnancy, despite perhaps my talk and also Laurie's talk, most of pregnancies in our patients with sickle cell disease do very well. And actually, provided that pregnancy is planned, we envisage that the outcome will be very good. So I suppose asking some of my patients what patients should know when they are planning a family. And most women will have a straightforward pregnancy. And that's very, very important to highlight. And I think that the importance of national guidelines, international guidelines, and making that freely available to families and also to multidisciplinary team becomes very, very pertinent. And that really allows the mother to know what to tell some of their clinicians if they are not used to managing pregnant women with sickle cell disease. And clearly you and your partner should meet ideally a specialist or a counselor to advise with regards to the options available to you. Ida alluded to the fact that, and very, very emotive, that clearly for her, she wouldn't wish anyone, let alone her child, to have the condition. And we think that every mother should have a choice to actually ensure that there are interventions available for her in preventing having an offspring with sickle cell disease. And that choice should be offered to her. And clearly the response in some countries is perhaps not for the couples to go ahead and marry or have a baby. And in fact, there are countries with churches not marrying couples, which I think inherently is wrong, which I think in terms of ethics is actually wrong. But the solution really is offered in pre-implantation genetic diagnosis. And most people on the panel through the Sickle Cell Society in the UK has actually fought tooth and nail to ensure that nationally this is funded by the government to ensure that mothers could have babies if they choose to, knowing that their partner may be a carrier, knowing that they may be at risk of having an offspring with sickle cell disease, to choose to have pre-implantation genetic diagnosis, which will avoid them going ahead to still marry, but avoid them having a baby with sickle cell disease. They should have a specialist team, and by that I mean obstetricians, sickle nurses, hematologists, working together to ensure that mother and baby are monitored closely. And by and large, if we do that, the outcome is good for the mother and baby. We have to be hopeful that there are treatments out there which over the years have made of mothers or women with sickle cell disease before they come into pregnancy. So hydroxycarbamide has been around for a long time. Preventative medications such as penicillin become very, very important. But still, there are gaps in terms of outcome for mothers with sickle cell disease, for adults with sickle cell disease. And hence, we have to keep the campaign going to improve research, to improve the care, innovative care for patients with sickle cell disease. Clearly, during pregnancy, we do not have the luxury of using hydroxycarbamide, crystalloximab, some of these newer medications, partly because they may actually have implication for the babies. We recommend that during pregnancy, If mothers are on hydroxycarbamide, they should stop it before pregnancy. But we have to be hopeful that the outcome will be good. And where the outcome may not be so good, we should be prepared to do research to bridge that gap. Clearly, a mother may ask, what are the important considerations? Will I need to change my normal treatment? Clearly, if they are on hydroxycarbamide, we will recommend they stop it if they are planning pregnancy. If they come into pregnancy already on it, we will recommend that they continue the pregnancy, that we stop that medication. What extra treatment might be needed? Clearly, Laurie alluded to preeclampsia being so common. We know that if we give that mother low-dose aspirin, either 75, either 150 milligrams, we prevent the risk of preeclampsia by 50% if it's given before 16 weeks. So it goes without saying we should give mothers with sickle cell disease low-dose aspirin before 16 weeks. What extra care would they need? Clearly, they should be on folic acid. During pregnancy, the risk of pneumonia is high. So if they are already not on penicillin, they should be started on penicillin to reduce the risk of pneumonia. At least every 4 weeks, they should see a specialist, both obstetrician and hematologist with an interest in sickle cell disease, and they should work together jointly, communicating where there are challenges so that they could address that together. Clearly, painkillers becomes important, and we ensure that the mothers have paracetamol, dihydrocodeine, but also they have a linked nurse that they can pick the phone to call if they have any doubts or if they have any questions. Importantly, all the centers should have guidelines on pregnant women with sickle cell disease. And ideally, it should be a national guidelines where there has been input from hematologists, obstetrician, patients, as well as nurses and midwives. First of all, the question is that when should I have a pregnancy? Clearly, this data, very complex, but I will try and break it down. Often in fertility specialist centers, anti-Müllerian hormone is a marker for ovarian reserve, for the number of eggs. And clearly for patients with sickle cell disease, the ovarian reserve, irrespective of age, goes down significantly. So don't leave pregnancy too late. And 15% of our mothers in where I work often have their pregnancies over 40. For patients with sickle cell disease, it's important to advise that they should have pregnancies. Perhaps under that age becomes very, very important because it may become difficult later on. Clearly, pre-pregnancy, they should have all the appropriate vaccinations, pneumococcal vaccination, meningococcal vaccination, hepatitis B vaccination, very, very important. And this day and age, clearly, COVID vaccination and flu vaccination. The partner screening becomes very, very pertinent. And in the UK, our patients with sickle cell disease are seen yearly. So the partner screening allow us to advise instead of clearly coming into pregnancy, not knowing their risk of having a baby with sickle cell disease. We can advise if the partner is the carrier, there may be 1 in 4 chance. For a patient with sickle cell disease, actually it's 1 in 2 chance, and offer them pre-implantation genetic diagnosis for free. And I have got patients who have come into pregnancy. In fact, I saw one today, having had a termination for a baby with sickle cell disease, then went on to have pre-implantation genetic diagnosis, 4 embryos frozen, the first baby that she carried, non-sickle, and 2 failed IVF attempts, and now pregnant again with unaffected baby. So clearly the life course could be planned appropriately where the mother have the choice of choosing not to have a baby with sickle cell disease. Clearly, these are the examples that we have published alluding to the fact that pre-implantation genetic diagnosis, when I first arrived almost 2008 at our center, the success rate was 18%. Now take-home baby rate is 63%. So it's clearly a viable option for our patients. And clearly countries may be advising not to go ahead with marriage because the partner is the carrier. If this is an option for our patients, then ethically they can go ahead and marry if they plan it. Laurie has alluded to the risk of preeclampsia, the frequency of crisis, anemia, infection, acute chest syndrome, cesarean section. But clearly, if we work together, if we have guidelines, some of these adverse outcomes can be prevented and the outcome will usually be good. And hence the need for guidelines, bringing heads together, communicating together will improve outcome for our patients. By and large, during pregnancy, they should be on folic acid. I've alluded to penicillin, and low-dose aspirin becomes very, very important. Consider thromboprophylaxis. Actually, I will say manage with thromboprophylaxis. For our first-time mothers who only complication is sickle cell disease, we start thromboprophylaxis from 28 weeks in terms of low-dose, low molecular weight heparin, and that improves outcomes significantly. We stop hydroxycarbamide, also crizanlizumab, we stop that. And if they are on other medication that may affect baby's development, we stop that prior to delivery. They will have serial growth scans because the outcome of the baby is very pertinent. And hence, from 20 weeks onwards, every 4 weeks, we will scan to ensure the baby is growing very well. And we are center that really believe in research during pregnancy to improve future outcomes. So we are beginning to work on placental magnetic resonance imaging to see whether we can distinguish some of the complications that may develop later on. Clearly, they may come into pregnancy with painful crisis. We ensure that they are well hydrated. We ensure the importance of housing. So we have community nurses who are linked to housing to ensure that if the mother is living in a housing that may be cold, they may have means to try and help them find appropriate council housing. Often the use of pain relief, again, we plan that so that by and large they will be on paracetamol, dihydrocodeine, and in some severe cases, oxycodone, but monitored very, very closely. And we allow the use of non-steroidals up to 28 weeks. And still, if they are in pain, they call our sickle nurse or come to our day unit in pregnancy, open 24/7 and be seen very immediately. And by and large, we advise our doctors to admit these patients in our high dependency unit to make sure that the most senior person sees them, to make sure that within 12 hours, our anesthetist will see them and alleviate the pain. They may be on patient control analgesia. It's important for us to monitor that very closely because sometimes they may have reduced oxygen as a result of that. And we do blood gases and we act on that very, very closely by doing a chest X-ray. VQ scan allow us to diagnose thromboembolism very quickly, including spiral CT. And really in these severe scenarios, we act multidisciplinary to improve outcome for our patients. You may say what happens in labor. Clearly, they would have seen our anesthetist before to plan in terms of what pain relief to have during labor. Some may have epidural, some may choose not to have epidural. And you should have a baby in a hospital that is able to manage sickle cell disease. Very, very important. And there are centers now in the UK actually marked for sickle cell disease or hemoglobinopathy. And it's important for our patients to know about. And all the other centers are linked into these central sickle cell centers to ensure that we are sharing the patients and we are sharing the learning. blood that is suitable should be available should we need it immediately. And we monitor the baby very closely in terms of continuous monitoring. They should be able to have a normal delivery, but we often advise the timing of delivery to be between 38, 40 weeks if there are no other complications, to ensure that the placental aging becomes important, more so for our patients with sickle cell disease if they go beyond 40 weeks. Clearly, what happens to the, after delivery, we ensure that we minimize the risk of crisis, so keeping well hydrated, ensuring that we've provided the thromboembolic advice, and all of our patients will be on low molecular weight heparin, which minimizes or prevents thromboembolism. We offer testing for the baby, goes without saying, where the mother has sickle cell disease or the partner is a carrier, then we actually do our test in the hospital before they go home. Otherwise, in the United Kingdom, there is universal screening for all newborns with sickle cell, for sickle cell disease by day 5. Contraception, very important. Clearly, progestogen-only pills is recommended, particularly if the mother is breastfeeding, or injectable Depo-Provera, implants, Mirena. So none of the contraceptions are a barrier if they are not breastfeeding. If they are breastfeeding, clearly they shouldn't be on combined oral contraceptive, estrogen, progestogen form of contraception. And if they are not, for some mothers, actually, this may be suitable for them. We will recommend not to write this off, but clearly important to ensure that they have no other risk factors like smoking in terms of ischemic heart disease or thromboembolism. And the copper coil is said to have a slightly increased risk of infection. So again, we recommend Mirena there for most of our patients where they may consider intrauterine system. So what can we do in terms of transfusion? Do we transfuse in pregnancy or not? Either alluded to some centers actually stopping the transfusion. Some centers also may routinely give transfusion, particularly at the end of pregnancy. So we ask ourselves, where is the evidence for this? You may ask ourselves, why are these complications? It may be because of the sickle cell disease, where the S percentage is very high. If we provide exchange transfusion, we will reduce the S percentage, and that may improve outcome. So fundamentally, there may be a rationale mechanistically behind this. So why not provide exchange transfusion? We've alluded to the fact that there may be side effects. It's important for us to do research about this. And what we've asked our funding body is that, do we need to do a definitive research to see whether prophylactic exchange blood transfusion may help? We cannot give the current medications that you can use outside pregnancy, hydroxycarbamide, crystallizumab. We cannot use this in pregnancy because of the concern with the development of the baby. I'm afraid we are left with blood transfusion. We have to find an answer by doing more research. But clearly, will our patients accept it? Will our clinicians, hematologists, nurses, obstetricians accept this? And hence, the trial that we've embarked on is called TAPS-2 trial, Transfusion Antenatally for Pregnant Women with Sickle Cell Disease. We know that for children, it reduces the risk of stroke. We know that for those having operations, it improves outcome. This may improve placental pathology and minimize some of the complications Laurie has alluded to. But will our patients accept it? The TAPS-2 trial is set to try and answer that. So this trial will assess the willingness of pregnant women with sickle cell disease to take part in such a study to address precisely whether exchange blood transfusion will improve outcome or not. The second study that we're embarking on is if a mother wants to know whether the baby has sickle or not. Currently, 2022, we put a needle into her tummy, take a sample of water from the around the baby or from the placenta to try and find out, can we not look at the mother's blood and actually identify the fetal DNA or the baby's DNA and avoid the risk of miscarriage associated with this? So far, we've done 64 of this, 57 we've got right, 7 we were unable to, the results was inconclusive. So clearly we've got funding to look at the further 100 to see whether this may prevent our mothers needing amniocentesis or chorionic villus sampling. I've given you our data on pre-implantation genetic diagnosis, which will answer precisely Ida's question of avoiding her baby having sickle cell disease. And finally, I feel that we may have a solution for sickle cell disease through women's health. And this is why your organization perhaps providing the advocacy to get funding into providing a cure for sickle cell disease may be so important. Wouldn't it be better if we identify a baby with sickle cell disease in the mother's womb? Most of our mothers are actually carriers of sickle cell disease, and in those mothers, they cohabitate with the baby for 9 months and tolerate each other immunologically for 9 months. Could the mother be a recipient, be a donor of stem cell transplant for the baby in utero to either provide the cure rather than offering termination, to provide a cure in utero for the baby to then carry on with a good outcome post-delivery and continuation of the child's life afterwards? Or in fact, the mother and baby may become tolerant to each other such that we can use the mother's bone marrow to cure the baby. This is where I will stop. Thank you.